It is true that as the biometric tests increase in our quest to bring the procedure to a higher accuracy level, they have become a necessary adjunct to assessing the patient prior to the procedure, as well, in a lot of cases, assessing the postoperative management of patients who had LASIK. So I think that most of these diagnostics have become a prerequisite for LASIK. They have in our practice. We, for many years now, cannot evaluate properly a refractive surgery patient without an epithelial, corneal epithelial map. Biometry, adaptive optics, wavefront topography, in many ways, tomography, reflection topography, are now intricate parts of evaluating refractive surgery patients besides the clinical refraction. And I think that although they may add a little bit more time and hardship in the pre-op and sometimes post-op evaluation, they definitely raise the bar as far as the accuracy and the documentation of what we're doing with the procedure. When there's a large number of diagnostic tests performed, there might be some conflict between two individual tests, and then the clinician is compelled to bring in a judgment of which one of the two or whether some of them will be repeated. I think it's crucial as the spectrum of cornea diagnostics and whole eye diagnostics increase to create an awareness of what each one of these modalities really represents and what the advantages and disadvantages of each one has. So we have worked a lot in trying to educate surgeons in regard to the pros and cons of each technology, and also trying to bring technologies that are not necessarily engaged in a specific platform in order to independently confirm some of the findings and measurements that we make. Indeed, the more testing performed, the more labor is involved for both the diagnostic and clinical team and patients alike. And the cost, both in hours used as well as the financial costs, are certainly a concern. But I think when it comes down to safety and efficacy of LASIK, these are always built into the procedure's success. And I think it's imperative when the technology is available to make it possible and available to each patient that's encountered. It's always interesting that with all the newer diagnostics and more things in the armamentarium on the side of treatment, whether we can expand the pool of patients that can have LASIK done. My personal opinion on this is that, for instance, combining partial CXL with routine refractive procedures should not be viewed as a means to treat forme fruste keratoconus with LASIK, for instance. We have designed, and it has been absorbed worldwide as a preemptive measure in those LASIK cases that are high risk, but not necessarily forme fruste keratoconus cases. They should probably be addressed with other means of intervention. But I think that's what's important is that even in cases that we have been routinely calling routine LASIK cases for the last 20 years, both this armamentarium of diagnostics and therapeutic devices are increasing our safety and accuracy. And LASIK was never more safe, it was never more accurate as a procedure. And I think that we, eye surgeons as a body, have become very much educated by all the experience that has passed through the years. And we have become better in selecting the patients, better in educating the patients, and better in transmitting what the procedure can achieve. And I think all these are crucial ingredients of having a happy patient, which is actually what we all work for. The question of how assessment of corneal biomechanics can affect LASIK is always very crucial. It's been a subject of research and some clinical investigation for over a decade now. We have seen measuring of ocular response, like the Aura instrument, the Corvus, and now there's a lot of research going on with the Brilliant concept, which I think is the missing piece, probably in my opinion the most important missing piece in preoperative and postoperative assessment in all laser vision correction surgery, more compelling so in LASIK, which we know does change corneal biomechanics dramatically. We have seen interesting work with the Brilliant concept. I think there's a lot more work that needs to be done before we can see it as a mainstream device. And I can only wait for the day that will be in our office and we can use it as a pivotal tool to pick those cases that may not be good candidates for laser procedure, or even in the postoperative course of a patient, identify those patients who maybe rub their eyes more or have a propensity for ectasia and be able to consult accordingly or preempt with a therapeutic procedure. I think artificial intelligence is always a very good helping hand in setting and reminding us things that we have acquired as knowledge through many years of trial and error, reports, research, etc. Through the last 20 years, looking at laser refractive procedures in the cornea, in LASIK in specific, I think that having AI as a tool to remind us where we can or cannot intervene, red flagging dangerous things in the cornea is pivotal for all of us, even busy LASIK surgeons, surgeons that refractive surgery is part of their everyday practice. And I think that it can only make our assessment and procedures safer and more complete. I think the global ophthalmic community has accepted CXL cornea cross-linking as the means of halting ectasia. We have seen also CXL as a means of modulating corneal biomechanics, and our team, along with others internationally, have worked in making it an adjunct in a significant number of routine LASIK cases in order to establish a better biomechanical profile and possibly more stable outcomes. We have reported both clinical work and basic science work establishing this foundation. And although I have to admit that in a global perspective, it's not accepted as mainstream currently, I can only convey to you that in our clinical practice, LASIK combined with CXL, LASIK Extra, as named commercially, is a routine procedure for all hyperopes. And we do see this in the hyperopic LASIK data as giving us more stable keratometries and more stable effect many, many years after procedure. And we engaged in LASIK combined with CXL in all routine LASIK cases that involve higher refractive errors in younger patients than 30, especially in a population that has such a high incidence of keratoconus. But I want to make a clear point that combining LASIK with CXL is not a means to treat suspicious corneas from Pru's keratoconus. It is just a means of enhancing the safety profile that routine LASIK has. Well, I think it's a very pivotal discussion for over the last few years. How do we educate people who wear spectacles, especially, or contact lens wearers, of the advantages of laser vision correction? And my personal approach to this is to just lay out the facts. I have personally chosen the path to not try and convince people to have laser, but to lay out the facts of what their visual function will be with contact lenses. It's always very important to at least have people try contact lenses for even an hour. There's a lot of people who are pushing back contact lenses because of comfort issues, and I definitely respect that. But under the same token, it's important for them to understand what their visual function will be with contact lenses, even if that's done within our facilities under our supervision, in order for them to be able to see the advantages and disadvantages between spectacle and contact lens use. Obviously, you don't have to do that in a patient that's already a contact lens user. But I personally think that having a laser vision correction procedure is a personal decision, and that we as physicians can reach up to the point to lay out the science, the reported facts, and try and entertain the questions and the lifestyle changes that each individual candidate may have. And I'm shying away from trying to convince people to have a procedure done. I think that sooner or later, people will reach a point, if they're willing to make that decision. And our work is to be working with them on that decision, not taking that decision for them. The question, what happens when a laser procedure, specifically LASIK, has gone through the years and now we have a residual refractive error, a new refractive error, is quite complicated. We have seen through many years that the go-to procedure is to lift the flap and enhance. For me, in my clinical setting, this is a much more complicated assessment because I want to go back and look at the early preoperative data and sense whether there's a change in the cornea, which would mean to me that the procedure has regressed, or whether what we have now as a new refractive error is lenticular change, a change in the lens. And obviously the age of the specific patient is again pivotal to this decision. For instance, if you're dealing with a 48-year-old lady who had 8 diopters corrected, and you're convinced that the keratometry 8 years ago is exactly the same with today, the obvious assumption is that there's lenticular change. And this does not necessarily change our decision in going to the lens or performing a LASIK enhancement or a PRK enhancement. And that decision between PRK and LASIK is done purely on the residual stromal bed, if you have concrete data on how thick the flap was, et cetera, et cetera. But I think it's important to make the patients aware, if you find the reason for it, where it's coming from. They need to be aware at that example age of 48 that this is a change in the lens, and we can fix it with laser vision correction enhancement, LASIK or PRK. But if the lens continues to change, then inevitably we will need to go to the lens to correct that. And I think diagnosis again, and the multitude of cornea diagnostics we have today may help us make the more accurate diagnostics that will help us make the more accurate decision. Well, I think the excimer laser industry has gone through a tremendous evolution. And we've looked at a lot of different excimer lasers as well as femtosecond lasers, and it makes it a very difficult decision to choose between them. I think the differences are quite minute. And in reality, looking at a lot of colleagues, both in Europe and internationally, that decision is a lot of times made in accordance with other associations that each individual practice or physician has with the industry. But I think that currently, and I say this with personal experience and with confidence, that the technology out there is fantastic, and there's very subtle differences between them. It is our systematic approach to diagnosis, formal informed consent, and optimal execution that will give us the best results.